presentation. So I've been asked to talk about thyroplasty, and I was very pleased to find this paper by Nick Gibbons and whoever Crowley is. I'm sorry if you're here, I don't know who you are, which gives a bit of the history. And thyroplasty started really a long time ago, and the first operations were pedicle wedge of cartilage. The problem with those was it died, the patient got horribly infected, and it all went very wrong. And then they used to put the cartilage through the inner perichondrium, worked for a bit, all went wrong, got infected, not good. Then they started putting it lateral to the perichondrium, that worked a lot better, and things progressed really until Ishiki in the early 70s described the thyroplasty, which was a game changer for voice rehabilitation. Now, it didn't take on very much until there were a few papers in the late 80s and 90s that actually showed that this was a really good technique. It then became the gold standard, so people started to use this much more frequently. So the advantages of the thyroplasty: you can do it under a local anaesthetic, you can do it under a general anaesthetic if you want to, but you can treat patients who are otherwise not really very fit. It's reversible if you want to, it's permanent, and you get immediate feedback during surgery if you're doing it under local, and it allows adjustment on the table. It has a low complication rate, and it has excellent outcomes with respect to voice, swallow and aspiration. Disadvantages: it's a much bigger operation than a local anaesthetic injection in the clinic. You have a scar in the neck. It's a longer, more invasive procedure. There is the potential for extrusion and other complications. And in my hands, it's normally done as an overnight stay. I know people do it as a day case, and I have done it as a day case. I've had a couple of nasty experiences having to go back to theatre and drain it in the middle of the night. So, it kind of puts you off really, but it is possible. So the complications: wound infection rate's pretty low. I usually give them a shot of antibiotics on the table, but there is an argument it's a clean operation, you don't need to do it, but we all have our little foibles. Airway compromise: if they get a bleed in the neck and they're not drained, then you can get an airway compromise, and obviously you have to sort that out, but that's pretty unusual. And then extrusion. So this is a slightly scary picture that you never want to see, but occasionally happens if the silicone has eroded through the vocal cord. You see a lot of granulations. Very occasionally, I had one patient who was coming in to have his implant removed, and he came out of the lift with it in his hand and went, "Oh, is this what we're looking for?" So that's not a happy situation, but it is reversible. You take them out, granulation tissue sorts itself out, and sometimes, because there's a bit of scarring, the vocal cord palsy is not so much of a problem and they don't need anything else doing. So there are several options for doing this operation, and really it depends on personal preference and what's available. So you need to make sure you get your measurements right, to get your window in the right place. It's very important to have the orientation of the window parallel with the inferior border of the thyroid cartilage. You've got the Montgomery implants there. I don't use those, I find them a bit big and inflexible. My preferred is with silicone, but that's very difficult to get hold of now. I don't know why, but it's to do with importing and marking, CE marking and things like that. For some reason it's not available currently, as far as I'm aware, in the UK. If anyone knows how to get it, please can you tell me? You can roll up some Gore-Tex and stick it in. You can use this little titanium implant here. And the top is a set of instruments that I bought when I was first appointed as a consultant 20 years ago, that I think were designed by Merritt Harris. But they're similar kits available with most of the implant systems. So, and you don't need any special kit. You basically need a ruler and a freer and a drill. So, mark the skin, expose the thyroid cartilage, you measure the height of the thyroid cartilage, you take a line back from the middle, and with the instruments that we've got a female and a male, distance marker, pitchfork, and then we've got the window marker that tells you how big to make it. Then you carve your little silicone block, you pop it in, that's it. Very easy. And it works very well. Now, that's all quite old history, but what's new is these new voice implants. Now, they are a combination of titanium housing with a silicone balloon on the bottom, so that gives a degree of adjustability. And the other advantage that it gives you is it rotates the arytenoid, so that posterior gap that's really difficult to sort out with a thyroplasty can be more easily improved. And there's a paper, and if you're interested in trying it, if you speak to, mine's gone blank, the company?
DP Medical.
DP Medical, they will arrange for you to have some training, and Floyd will come and show you how to do it. It's good fun. So, this is my case.
This is my voice on the 22nd of November 2022, the day I go in for surgery. This is my voice on the 23rd of November, the day after my surgery. This is my voice on the 14th of December 2022, 3 weeks and 1 day following surgery.
So this is a voice case, but you know, it would be similar with any form of thyroplasty, one hopes, but not always. And this is her post-op laryngeal appearance. Sorry, there's no sound on there. So she's getting good closure, nice closure at the back. She's very happy with her voice. And just a little aside about scars, because I'm a Botox nut and I stick it everywhere, just about. At one of our botulinum BNN conferences, there was a lecture given by one of the plastic surgeons about using it in wounds, and it's brilliant in wounds. So this is her scar 3 weeks after the surgery, and there's various papers about doing it, but basically if you put botulinum toxin, doesn't have to be Botox, into the scar, it reduced fibroblasts, it reduced redness, it stops the muscle pulling so you don't get stretch, and it just gives much nicer scars. So that's it, that's me.